I'm Ekaterine Ruadze from the National Center for Disease Control and Public Health, and I will be representing here the outcomes and results of a study called The Effect of Psychological Support on Patients' Retention on HIV Care, based on 2013 cohort. At present, Georgia experiences HIV concentrated epidemic among men who have sex with men, with 25% of prevalence. The lowest prevalence was observed among female sex workers with 1.3%. Among injecting drug users, HIV prevalence is capped at 2.2%. HIV/AIDS response is mainly funded by the Global Fund to fight against malaria, tuberculosis, and HIV. The Global Fund finances 3 dimensions, which is the prevention, the treatment, and the psychological and informational support. The preventive activities are implemented by the different NGOs. The AIDS Center is in charge of the treatment activities, and the psychological and informational support is implemented by HIV/AIDS Patient Support Foundation, which in short we call HAPS, and maybe later during the presentation I will using the abbreviation HAPS, so I mean the Patient Support Foundation. Apart from, before I go to the objective, I want to add that apart from the Global Fund activities, the state also funds some screening activities for pregnant women, for prisoners, and for blood donors, but it's only screening. The treatment is universal. Georgia has universal access to HIV treatment. It's free of charge for anybody who is infected with HIV. The objective of the study was to assess the effect of psychological and informational support on the patient's engagement in HIV care. For the study, we included everybody diagnosed with HIV in 2013, and we followed them until the end of June 2015. So therefore, the minimum follow-up time was 1.5 years, and the maximum follow-up time was 2.5 years. We defined exposure as at least 1 documented contact to HIV Patient Support Foundation, and we had multiple outcomes. Those are the stages of HIV care cascade. We did descriptive analysis, of course, using percentages, median values, interquartile ranges, but we also did tested association between the exposure and the outcome variables using Cox regression. This figure represents the care cascade, the cohort care cascade, based on 2013 cohort. Well, in 2013, 488 people was diagnosed with HIV. If you can see, we do not lose many people from one stage to another. However, if you compare the number of people of suppression reached at the end after 6 months of treatment to the total diagnosed people, you discover that only 39% of those diagnosed with HIV is among those reached with suppression, so viral load suppression. Among those 488 people, only about 28% sought support from HIV People Support Foundation. Well, mainly they went there for informational support because they wanted to know more about the disease. About quarter of the cohort went there for psychological support, but the rest, about 35%, were for general type of consultation about what to do, about the disease, and etc. Mainly, 73% was face-to-face contacts, followed by telephone contacts, and then only 4% used online contacts. This table represents the distribution of way of transmission among those applied for HAP services and among those not applied for HAP services. Well, it's more or less the same kind of distribution between these two groups. However, it has to be said that among those applied for HAP services, almost half were those contracted HIV through heterosexual contacts, followed by IDUs, and only 15% of the population went to HAP services were MSM population. The median duration of time from diagnosis to going to the HAPs was 3 months. The shortest median duration of time was homosexual contact, a month and a half, followed by heterosexual contacts with 2 months, and for ID users, it took for median cohort, it took 6 month time to go to the HAP services. If we compare the proportions between the HAPS cohort and no HAPS cohort, we see that within the HAPS cohort, at each stage of care cascade, they have better retention proportions than no HAPS cohort. And these differences are statistically significant, apart from those having viral suppression reached. The Cox regression analysis also showed that the people, those have psychological and informational support, they have more likely to be linked to care, they are more likely to enroll on ART, being their viral load count after 6 months of treatment and reach their viral suppression. And from this analysis, we'll see that being with HAPs is a protective factor against loss to follow-up. So people those have this support, they are less likely to get lost during the treatment. Actually, for obvious reasons, AIDS Center as well as HAP Center registers people, patients, according to their way of transmission of disease. What they ask them is how you transmitted the disease, and if it says injecting drug use or MSM contact or heterosexual contact, they put there. While for maybe policymakers, for public health providers, it's maybe much better to know the behavior groups, what's happening within behavior groups. And the way of transmission and behavior groups not always coincide to each other. And when I was talking during presentation about the MSM, about heterosexual contacts, and about homosexual contacts, I meant the way of transmission rather than risk group or key affected population. And the sample size, although we included everybody who was diagnosed with 2013, which means that, sorry, we were restricted with this cohort number. So with bigger sample sizes, it's always better. The results are more trusted, more validated, etc. However, the analysis methodologies we have employed is quite good. So we still think that the results are valid. However, with bigger sample size could be more interesting maybe. But we think to do this study for bigger sample sizes as well. Well, we observed that only 30%, or a bit less, 28%, those diagnosed with HIV in 2013 applied for HAP services. Not everybody, 30% is like a third of the cohort, which is quite low. The barriers can be like they might don't know about such services, or maybe they do not trust them, or maybe they prefer that their HIV status not to disclose to everyone, and maybe they want it to be kept up to limited people, maybe doctors, very close family members, and not everyone, and or maybe they receive such services from somewhere else. Maybe they have doctor, they have psychologists, the private ones, and they get all the support they want, or maybe they read and they don't find it necessary to go to a special NGO to get some support. In conclusion, I want to say that obvious from our analysis that the population was applied for HAPs, they have better uptake and better rates of retention at any stage of care cascade. and they have higher rates of IRT initiation. I highlighted the higher rates of IRT initiation because, as you know, the WHO now recommends treat-or policy, which means that everybody who is diagnosed with HIV should be treated despite their CD4 count. Before it was like CD4 count 500, then it was 350, 100, 200, and now it's everybody because it's shown epidemiologically that well, in 86% can be reached with suppression, and they do not transmit the disease. This is like secondary prevention of disease transmission. Well, the recommendation is very simple and very obvious. Of course, hub services should be promoted even further and should be encouraged people to go there. And well, the MSM population is the most stigmatized population in Georgia. They are hidden population, and it's very, very, very difficult to reach this population. And as we also saw, the online contacts, only 4% of people applied for this, and MSM population are active on online contact rather than on face-to-face contact of telephone. So I think that one of the recommendations could be that to encourage online contact for MSM population, especially among MSM population. And I'm very thankful to AIDS Center and Hub Center because they gave me data to analyze, and they helped me to contact these two data to each other and do the analysis. And thank you to all of you.
Thank you, Ekaterine, for this very nice presentation. I like your discussion. You give us a lot of information, but still, if anybody wants, we have a possibility for maybe 2 questions to Ekaterine. Is there any question? Yes, Senad? Yes. Okay. 2 questions, okay. Senad? Okay, give the floor to lady, okay? You are gentlemen.
Thank you. I'm Aileen Kitching from the MediPIET Alumni Network. Thank you very much for a really interesting presentation. From what I gather from your presentation, it was really a quantitative data that you looked at. So it was data you got from the organization.
Yeah, I got the data from AIDS Center and from Hub Center, and I did not say, but it was on the slide, that the data is routinely collected. So we just extracted data from the data set as of October 2015. It's in my methods, but I did not say in a speech here. So that's and the AIDS Center has very good data set. They register each and every patient. As long as they start treatment, and they have literally every step of the patient, when they do the analysis, when they pick up the medication, etc., etc.
Okay. Yes. I suppose the question I was wondering, do they also collect data on things like condom use or whether they've been diagnosed with STIs? Because that would be really interesting to look at.
Yes, absolutely. Thank you very much for this question. Okay, they do not do. AIDS Center does not do collect information about this. However, we have the separate data set, which comes from NGOs, because it's NGOs those work for preventive packages. And right now, back home, my colleagues are working to create the data set which can capture everything and to have one unique data set for HIV/AIDS. Yeah, that's a pitfall, I know.
I think that would be really interesting. I work on HIV and STIs in Ireland, and I suppose what we're seeing a lot is kind of the low use of condoms. And you know,
yes, absolutely. MSM population, they do not want to use. There are many things happening.
So it would be really interesting to see with this impact.
Yes. Okay. Thank you, but it was not possible now.
Thank you, Eka. Thank you for the beautiful presentation. So, I have more comment and a question, and that is first the question and then the comment.
Okay.
So, is Georgia Global Fund eligible country?
Yes, it is still. We are in transition, and right now, as I said, back home, right now, my colleagues are still working to develop a transition plan. So we are developing, and we already managed that HIV/AIDS first-line medication for treatment is bought by the state budget. And now we have a plan now from June 2016, it will be OST programs taken by the state program, by the state government, and then slowly. And I don't know, there is a discussion that maybe at given moment, maybe the state is more ready to take treatment activities rather than prevention activities. However, well, we will see. At least we have a project until the end of 2019. So before that, we will be more clear what the state is doing, where we are, how we are doing as a country. So, yeah, that's it. Yeah.
I was afraid that you're going to answer that in that way, because experiences in the region are showing that countries who are not longer eligible for Global Fund support have failed to conduct the activities in the very same manner while they were conducting it with the Global Fund assistance, which resulted unfortunately in significant raise in...
It's like Romania was one of the examples, for example, and when Global Fund went back to the country. Yes, thank you for this. This is a big worry in Georgia, but no, we do our best. Let's see, because well, maybe prevention packages will be with us, with Global Fund, for a bit longer period. I don't know how good is a bit longer. What does it mean? But it's treatment. Yeah.
Thank you.
Okay.
Thank you. Really.
Is there any other question for Ekaterine? No? Then thank you. I think that you very well highlight the importance of such population like MSM, who are the leading regarding the prevalence, just how to motivate them to be on treatment, and also I hope that Georgia will change the recommendation for the treatment, because it's important, as you said, not to be those who are only with CD4 less than 305, but to include everybody.
Yes, because what WHO recommended, so we have to do this.
But you need to have money and investments in that.
Yes, but yeah, I know.
Okay. But thank you.
Absolutely. Thank you very much to everyone.